Good morning. I welcome you all in this online teaching program. I, Dr. Anil Kumar, Head of Department, Pediatrics, Government Medical College Bettiah, along with the students of the 2016 batch, we are going to discuss a very important topic, that is iron deficiency in children. As we know that the deficiency of iron leads to anemia. So first we will define that what is anemia. The anemia is reduction of the red blood cell, that is RBC volume, or hemoglobin concentration below reference level for the age and sex of the individual. Other very important definition is the hemoglobin less than -2 standard deviation or 95th centile for age and sex. WHO has also defined anemia on the basis of hemoglobin threshold. Here the chart given with the different age groups with the different hemoglobin threshold value. Amongst the different etiological factors in the causation of anemia, we are going to discuss a very important topic, that is iron deficiency anemia. Let's talk about the total body iron. In the full-time infants, approximately 75 mg per kg. In adult males, 50 mg per kg. In female, 35 mg per kg. The iron can be divided into functional, that is 80%, and in the storage form, that is 20%. Iron deficiency anemia is the most common cause of anemia worldwide. The most important cause of iron deficiency anemia is parasitic infections, hookworms, whipworms, and roundworms. We should talk about the general features. Newborn contains 0.5 gram of iron, adult contains 5 gram of iron. A diet containing 8 to 10 milligrams of iron daily is necessary for optimal nutrition. 1 milligram of iron must be absorbed each day. That takes place in the proximal small intestine. Absorbed 2 to 3 times more efficiently from human milk than from cow milk. Meat, liver, kidney, egg yolk, green vegetables, fruits, these are the important iron sources, whereas cow milk is a poor source. Different sources of heme iron and non-heme iron are given below. Now we will talk about the iron metabolism. Distribution of body iron in adults is given below. The hemoglobin 2.3 gram, storage in the form of ferritin and hemosiderin 1.0 gram, non-available tissue iron 0.5 gram, transport iron 3 to 4 milligram. The total iron is approximately 5 gram. Iron absorption depends upon body stores of iron, rate of erythropoiesis, iron needs of the body. The iron absorption can be increased in the presence of vitamin C, fruit juices, lactose, amino acids, cysteine, lysine, histidine, and gastric HCl. The absorption can be decreased in the presence of phytates, tannic acid, calcium salt, and phosphates. Diagrammatical presentation of iron metabolism is given below, in which we can see that iron comes from the diet. Ferrous absorbed by the active transport. Transferrin protein transports ferrous in the plasma. Liver stores excess ferrous as ferritin. Bone marrow uses ferrous to make hemoglobin. Spleen converts hemoglobin to bilirubin. Liver metabolizes bilirubin and excreted in the bile. Bilirubin metabolites are excreted in urine and feces. Diagram showing nutritional iron balance is given below. Pathogenesis of iron deficiency anemia are increased physiological demand, as in the case of growing children, especially in the age group in between 6 to 24 months, also in the adolescence group. The pathological blood loss due to any chronic loss, inadequate intake of the diet rich in iron in case of nutrition deficiency, or decreased iron absorption, or there are some chronic diseases like tropical sprue and celiac disease. High hemoglobin concentration of the newborn falls during the first 2 to 3 months, especially in the physiological anemia of infancy or anemia of prematurity. The considerable iron is stored, usually sufficient for blood formation in the first 6 to 9 months of life in term. Now we will discuss etiology in details. The most important cause worldwide is infestation with parasitic worms. Hookworms suck about 0.03 to 0.2 ml of blood per worm per day. Whipworms and roundworms. Dietary insufficiency and malabsorption. Chronic blood loss in the form of occult bleeding, that in the case of peptic ulcer, Meckel's diverticulum, polyp, hemangioma, inflammatory bowel disease, intravascular hemolysis, and hemoglobinuria, chronic diarrhea, and milk allergy. Risk factors given below are demographic, more important for the elderly, teenager, female, dietary, low iron, low vitamin C, excess phytate, tea, coffee, social and physical, poverty, alcohol abuse, and GIT disturbances. In clinical features, pallor is the first and most important sign. We will look for the pallor in face, nails, palms, conjunctiva, mucous membrane. Phagocyphagia is also important cause. Anxiety, poor appetite. If the hemoglobin below 5 gram, then patient will be irritable, and anorexia will be the prominent feature. Tachycardia and systolic murmur, dyspnea, and palpitation are the important features in the severe anemia. Hair loss, fainting, sleepiness, tinnitus, mouth ulcer, glossitis, angular cheilitis, constipation, depression, twitching muscle, tingling, numbness or burning sensation are the some important clinical features of the anemia. This picture showing angular stomatitis is an important sign of anemia. Koilonychia, that is spoon-shaped nails, Platinichia, weak brittle nails, pruritus, dysphagia due to a formation of esophageal babes, an important component of the pulmonary immunosuppression syndromes. These are the important features of the anemia. This slide showing spoon-shaped nails. Some important clinical feature of anemia: abnormal neurological and intellectual function, affects attention span, alertness, verbal learning and memory. Monoamine oxidase, an iron-dependent enzyme, has a crucial role in neurochemical reactions in the CNS. Breath holding spell is also an important feature of anemia in toddler. Response to low hemoglobin: first, the tissue iron stores, represented by the bone marrow hemoglobin, disappears. Serum creatinine decreases. The serum iron level further decreases. The serum transferrin decreases. Iron binding capacity increases. Percent saturation, transferrin saturation falls below normal. Free erythrocyte protoporphyrin accumulates. Later response to low hemoglobin will lead to the microcytosis, hypochromia, poikilocytosis, and increased RBC distribution width. The chart showing selected cutoff values to define iron deficiency. Diagnosis can be made by following laboratory investigations. Complete blood count, in which we can get the high RBC distribution width that reflects an increased variability in the size of red blood cells, a low MCV, MCH and MCSC. Hemoglobin and hematocrit value will be low. Reticulocyte count will be normal or moderately elevated. Other important investigations are examination of peripheral blood smear, in which we can get microcytic hypochromic anemia, charged cells, hypochromic pencil-shaped cells, and occasionally a small numbers of nucleated RBC. We can get thrombocytosis due to it activates the thrombopoietin receptors in precursor cells which make platelets. Diagnostic tests show serum creatinine low, serum iron low, serum transferrin elevated, total iron binding capacity high, stool for occult blood, and stool routine microbiological examination showing hookworm, V-worms, or roundworm. Ratio of serum iron to TIBC, called iron saturation or transferrin saturation index, is the most specific indicator of iron deficiency. If it is less than 5%, it indicates iron deficiency. This chart showing different indicators for the diagnosis of iron deficiency anemia. By this chart, we can differentiate between iron deficiency anemia, alpha-beta thalassemia, and anemia for chronic diseases by the different indicators present here. The bone marrow aspiration examination showing bone marrow is hypercellular with erythroid hyperplasia. Leukocytes and megakaryocytes are normal. No stainable iron in marrow reticulum cell. This slide showing normal peripheral blood smear. This slide showing normal peripheral blood smear and anemic peripheral blood smear, in which there are a less number of RBC present here. This chart showing different laboratory tests in iron deficiency anemia of increasing severity. The mainstay treatment of iron deficiency anemia is oral iron therapy. It should be given in the dose of 3 mg per kg of elemental iron, given once or twice daily. It should be given 30 to 45 minutes before meal or 2 hours after meals, and only with juice or water rather than with food or milk. If the age is less than 12 months, we can give iron fortified formula, a cow milk based formula, unmodified cow's milk, non-formula cow's milk should not be given to infants. If the age is more than 12 months, then intake of the cow milk should be limited to less than 20 ounces per day and bottle feeding should be discontinued. Deworming. Complete blood count is re-evaluated in 4 weeks when the child is healthy. If the hemoglobin has increased by 1 gram per dl, therapy is continued and a complete blood count is retested every 2 to 3 months until the hemoglobin reaches the age-adjusted normal range. Oral iron is continued for an additional 2 months after the hemoglobin reaches the normal range for age. The table showing dosage schedules for iron supplementation to prevent iron deficiency anemia in different age groups. Oral iron failures may be due to incorrect diagnosis, as in the case of thalassemia. Patient is not taking the medication, not absorbed, enteric-coated, the case of malabsorption syndromes, gastrectomy, celiac disease, rapid iron loss, anemia of chronic disease that impairs the bone marrow response. Parenteral iron preparation in the form of iron dextran is indicated when there is an intolerance to oral iron, severe gastrointestinal complaints. Packed or sedimented RBC should be given when the hemoglobin value less than 4 gram per dl. In the case of congestive heart failure, we can give fresh packed RBC. We can judge the success of our treatment by responses to iron therapy. In 12 to 24 hours, there is a replacement of intracellular iron enzymes, subjective improvements, decreased irritability, increased appetite. In 36 to 48 hours, initial bone marrow response, erythroid hyperplasia. In 48 to 72 hours, reticulocytosis, peaking at 5 to 7 days. In 4 to 30 days, increase in hemoglobin level. In 1 to 3 months, depletion of stores. We can prevent iron deficiency by following measures: by encouraging breastfeeding exclusively for 6 months. More than 4 months, an additional source of iron should be added, first as an iron supplement, then transitioning to iron fortified infant cereals. Less than 12 months who are not breastfed or are partially breastfed use only iron fortified formula, 12 mg of iron per liter. 6 months encourage one feeding per day of foods rich in vitamin C. Avoid feeding unmodified non-formula cow's milk until age 12 months. 1 to 5 years should also consume an adequate amount of iron containing foods to meet daily requirements. Thank you for your attention.